Good morning, Randall. And good morning to all of you. Thank you so much for taking the time to join us for this morning's QI Power Hour. My name is Chelsea Schwartz, and I'm joining you today from my office in Saskatoon, located on Treaty 6 territory, the traditional land of the Dakota, Lakota, and Nakota, and the homeland of the Métis. I'm a settler to this land. I grew up in the southeast corner of Saskatchewan in Yorkton, but my ancestors originally settled in Nova Scotia from Scotland, Ireland, France, and the Netherlands. I would like to pay my respects to this land and its traditional caretakers, and I too commit to taking care of this land I call home, and all the people living on it. I commit to using the privileges I've been afforded to contribute to a new shared future where all cultures thrive and all people have what they need to live healthy lives. And if you know the traditional lands that you're joining us from today, I invite you to share that in the chat now. For those of you who may be joining us for the first time to QI Power Hour, a very special welcome to you all. A question we often get is this session being recorded? And the answer to that is yes. We will be recording this session, so if you do have to hop off early, just know that we will send you an email letting you know when the session has been posted to our website and how you can access those materials. We also invite you to check out other sessions that you may have missed that may pique your interest. I was noting this morning that we are currently on session number 48 in the QI Power Hour series. So what started out as a small test of change in 2007 has now grown to a wide audience. So thank you for the privilege of your time, and we appreciate you being here. While you're on our website, we also invite you to sign up for our distribution list. And this will make sure that you don't miss any of our upcoming sessions. So you can access that link to sign up for our distribution list from our Health Quality Council website. And as I mentioned, we originally started out with a small group of folks, primarily improvers within our Saskatchewan healthcare system. But we've just been so humbled and honored by the spread of our learning community to organizations and sectors with an interest in the health and well-being of our communities, both within our province of Saskatchewan, as well as across Canada, and even internationally. So thank you again for sharing an hour of your time with us. And thank you for your commitment to improving the systems that you're each part of. So just by way of housekeeping, I would love to just onboard you to the chat function. So I see lots of you have found it already. I've been seeing our chat busy with all of the folks letting us know where they're joining us from today. So thank you. If you're still wondering, how do I get those words to pop up on my screen? We'll just invite you to launch the chat panel by clicking on the chat bubble at the bottom of your screen, bottom right-hand side of your screen. And this will launch the chat panel where you can then send your questions, your comments, your ideas, your reflections from today's session with everyone in the chat. So we do invite you to just select in your to field, everyone, and that way everyone will be able to take part in the conversation. If you are active in Twitterland, we also invite you to tweet out during today's presentation. You can use the handles QI Power Hour and HQC Sask and the hashtag QI Power Hour. And with that, I would love to pass things over to our main event. So welcome, Randall. Thank you so much for sharing your time with us. Randall works with Alberta Health Services as the Senior Advisor for Indigenous Populations. He's also the owner of Mackenzie Indigenous Health Solutions. He's managed multiple projects exploring the addiction and mental health service needs of vulnerable populations, which we'll be sharing a bit about today. Randall has held various management positions in social care and health organizations in Saskatchewan, Alberta, the UK, and New Zealand. Randall holds a bachelor's degree in social work and has advanced certifications in quality improvement, change management, and project management. Randall is a proud member of the Montreal Cree Lake in Saskatchewan and currently resides in Edmonton with his wife Liv, their baby Mackenzie, and their bulldog Jizzy. So I will pass things over to you, Randall.
Tansi, mio kisipia, Randall Bell nesitigasan. Muni au sagahigini, kisigutu. Itaskita ni hidao ni Montreal Lake ni hidao national che. Ni the nanuma. Ni hida waka siniskago che, o te Saskatchewan. Kuyas ni machihigo. Ni wagamagana. Tautoki siro. Hello and good morning. My name is Randall Bell. Montreal Lake is the name of my homeland. I'm a Cree member of Montreal Lake Cree Nation, and we are the Cree people from the Rocky Place in Saskatchewan. My people make me proud each and every day. Now, Montreal Lake Cree Nation is one of the many signatories of Treaty 6, and I'd like to acknowledge again that I'm on Treaty 6 territory here in Edmonton, and as is our gracious host in Saskatoon. But healthcare affects all treaty territories, and it affects all Canadians. So the work we do must be done in the spirit of partnership and reconciliation. So let's start today by acknowledging the land that we're on, the partnership that is needed, and ultimately our firm commitment to reconciliation. Okay. So before we begin, I'd just like to say thank you to Chelsea for the invitation and for the opportunity to share this work with everyone here today. I'm hoping you'll find it interesting, informative, and helpful in the work that you do. So we're going to talk a little bit about the background of this particular project. Why do we need an Indigenous Patient Journey project? Well, there's a long trail of documents, and it's a lot longer than this slide, but you know, the UN Declaration on the Rights of Indigenous Peoples comes out in 2007, and quote, Indigenous individuals have a right to the enjoyment of the highest attainable standards of physical and mental health. Creating Connections is the Addictions and Mental Health Strategy 2011. And it said that we're going to be identifying and addressing gaps in service delivery and by customizing services to meet the needs of First Nations and Métis individuals. Patient First Strategy comes out 2015, talking about proactively listening and honoring and respecting patient and family values, expressed needs for culture. Truth and Reconciliation, of course, also in 2015. TRC 19 spoke to the need to establish measurable goals to identify the gaps in health outcomes between Aboriginal and non-Aboriginal communities. Mental Health Review comes out in 2016, another AHS kind of strategy. This is saying that the continuum of addiction mental health services from prevention to recovery, which needs to include traditional, cultural, and clinical approaches. So there's quite a long history leading up to this particular project, and so it was a much needed project, and we were very happy to get it moving. So this is a good visual for what happens when we design services without consulting service users, right? Quite often, service users will go only to the services that work for them in a way that works for them. And so for a lot of Indigenous service users, this means not using services at all. So it's important that we listen to service users, but it's even more important that we learn from them. So to talk a bit about this project, we interviewed 200 Indigenous service users. IPJ examined the needs of 100 high-need service users. IPJ2 looked at 100 incarcerated Indigenous service users. Ultimately, we were looking for what was working, what was not working, and what was missing in the addiction and mental health service continuum, the services that were delivered to Indigenous people. We set out to capture the service user's perspective on AMH services, to capture that service user narrative. So how do we go? So interviews for IPJ1 started in 2015 and concluded 2016. We interviewed in 13 locations. Interview sites were typically community-based organizations. CBOs, treatment centers, on reserve health centers. IPJ2 started in July 2016 and concluded in August 2016. There we interviewed 7 correctional centers across Alberta in Edmonton, Red Deer, Calgary, Peace River, Lethbridge, and Medicine Hat. Oh, and Fort Saskatchewan. So IPJ1, the challenge was really finding willing partners and also interview participants. In IPJ2, identifying interview sites was a lot easier, and we're quite often finding a more captive audience. Sorry, little dad joke there. My wife would probably kill me for that one. Okay, so let's jump into this. IPJ1, we had an N value of 100, convenience sample, of exactly 100 Indigenous men and women. These were predominantly homeless individuals, multiple episodes of inpatient care in addiction treatment facilities or mental health treatment facilities, or both. You can see there that we had 73% for status, self-identifying as status, 17 self-identifying as Métis, 7% non-status, and even 3% Inuit. Average age falling between 40 and 49. So a pretty good mix of people. And IPJ2, we interviewed a sample again of 100 Indigenous men and women in correctional centers across Alberta. And so average age there being between 18 and 30. Indigenous status, again, 8% status. Self-identifying as status, 16% Métis, 4% non-status. Unfortunately, no Inuits are identified in that particular convenience sample. So the project interviews examined 6 key areas. We looked at service awareness, service access, service delivery, the availability of culturally safe services, service transitions, and we included a piece of trauma inventory. I'll get into that in a little bit. Understanding the service user starts with understanding the service needs, which brings us to the next slide. So looking at adverse childhood experiences and trauma exposure throughout the lifespan can help us understand the experiences that have shaped those service needs. Dr. Vincent Felitti did the ACE studies and did a long-term analysis of over 18,000 adults. They found a strong relationship between traumatic experiences as children and poor physical and mental health as adults, ultimately leading to an early death. I'm not going to get too much into ACEs. I'm sure many of you are aware of the ACEs studies. Now, our trauma inventory was certainly inspired by Felitti's work, but we wanted to understand the ongoing element of it, the lifelong trauma experience of Indigenous populations. And we looked at their experience not just in childhood, but their teenage years and adulthood as well. And those of us who work with vulnerable populations know that trauma exposure rarely stops on someone's 13th birthday. It often continues into their teenage years and well into their adulthood. So we also consider the contributions of other stressful life events and the development and prevalence of dysfunction or destructive behaviors, self-destructive behaviors. So you can see here that we had 2 populations that had very high levels of trauma in a number of different areas, a lot of substance use issues, and essentially a lot of issues that were contributing to service needs, as it were. So the values for the corrections populations participants who attended residential schools was more than double the high need service users at 57%. The values of mental health problems in the corrections population nearly double the high need service users at 80%. So you start to see a picture of a very complex group of people with very complex needs. Not sure what happened to this slide on screen, but we'll try to get through it as best we can. Anyways, there must have been something in the formatting transition to WebEx. So after studying the adverse experiences and trauma exposure of 100 high-need service users in IPJ1, we saw two patterns emerge. The first pattern is that adversity and trauma was most common in these 7 areas: abuse, mental, physical, or sexual, family, tragedy, accidental death, suicide, or homicide, mental health problems, physical health problems, relationship breakdown with the family, such as divorce, separation, foster care, parental incarceration, etc. Relationship breakdown with friends, dysfunctional relationships, that kind of thing. The second pattern we saw was that the level of adverse experiences and trauma in these 7 areas tended to increase with age. So looking at the graph, we see that the center loop represents the childhood of the high need service users. The middle loop represents their teenage years, and the outer loop represents their adulthood. And while the lifespan of, sorry, I lost my thing here. While the lifespan increase of all 7 areas were alarming, it's important to note that substance use and addiction remains the highest of all 7 through the lifespan. So we thought this was as bad as it would get, and clearly we were very much mistaken. When we looked at the corrections population, we saw that substance abuse in adulthood jumps from 88 to 98. Mental health problems jump from 76 to 95. Relationship breakdown goes from 69 to 92. So it's clear the corrections population are extremely high needs population with very complex needs. Okay. Moving along. Sorry, I'm having technical difficulties here. Second, bear with me here. Oh, this one. Okay, sorry. So when we think about adverse childhood experiences of the corrections population, it really comes as no surprise that they were asking for help at a younger age. Corrections population first accessed services between the ages of 13 and 18 years old, compared to 16 and 21-year-old high need service users, IPJ1. The corrections participants who access services before age 12 is more than double the high need service users. In terms of mental health and awareness, upwards of 95% of the 200 people we interviewed had poor mental health literacy. The vast majority denied ever having issues related to mental health. It was only when issues of mental health were described as symptoms like anxiety or depression or suicidal thoughts or persistent nightmares, phobias, irrational fears. It was only then participants would say, "Oh yeah, I've had all those since I was a little kid." So clearly a very poor, a large population with very poor mental health literacy, and now that creates serious barriers when you're trying to access mental health supports. Okay, the screen here. Access and awareness to addictions and mental health. So when we look at the barriers to service access, we see transportation is a real problem for vulnerable populations. Out of the 200 people, 158 people said transportation was a barrier. But we also see lack or absence of personal ID as a really big barrier to service access, and even more so in the corrections population. The absence of a family doctor or GP is also identified as a significant barrier. And without a GP, things like patient histories and referrals and pre-treatment medicals become significantly difficult. Without ID, it's hard to get a health card. Without a health card, it's hard to get a GP. So these barriers are quite often linked together. So service delivery in AMH. When we asked both samples what was working well for them in terms of engaging addiction and mental health services, The results between the corrections populations and the high needs service users were vastly different, but weren't vastly different, but did have a few surprises. Both the high needs service users and the correction service users valued clinical staff that were understanding above all else. And when we think about the trauma exposure in the corrections populations, it should come as little surprise that the corrections populations have much larger emphasis on the importance of clinical staff being trauma informed. They know what they need and they know what works for them. AMH, culturally sensitive services. So the corrections population reported a lower value for whether or not they perceived addiction and mental health services to be sensitive and responsive to Indigenous persons. And if we consider the majority of Indigenous persons needing addictions and treatment, were typically referred to a culturally sensitive program provided through AHS or through NADAP, one would expect more than 41% of them would indicate they felt staff were responsive to their needs as Indigenous people. So while AMH and contracted service providers are making real strides in developing culturally sensitive and responsive services, it's clear we have a long way to go. Sorry. Difficulties every time. So now we're talking about addiction and mental health service transitions. You can see on the left aftercare support and so the corrections population reported higher values for difficulties in all categories of service transition. Transition out of AMH services is a particularly stressful time for AMH service users, and it's a time of great vulnerability. Discharges from treatment centers can occur with homeless individuals having no idea where they're going to next. Likewise, releases from correction centers can occur late at night or in the very early morning hours, regardless of whether or not that person has somewhere to go. So the uncertainty, that vulnerability, the substance abuse history, and obvious socioeconomic factors make robust transition planning all the more crucial to AMH service delivery and support with these populations. So the IPJ cycles. Okay, so I'll just read this this one quote from a 34-year-old female here in Calgary Remand Center. Said the more information programs that offer insight while transitioning, because not many people make it through transition. People incarcerated, they often end up back because of conditional release, and they do not have the support or cannot live up to the conditions and end up back in prison. Transitioning to any services becomes difficult. The stress of that causes relapse. And I wanted to share that because she really wraps it all up and really kind of gave me that light bulb moment of seeing this constant reoccurring cycle when we're going through the patient journey process of a number of these different participants. And essentially what we saw beginning to end is the Indigenous person, high levels of trauma, as we've discussed in previous slides. They described numerous socioeconomic factors to bring that brought them to where they are in their current lifestyle, I suppose. Issues with education, employment, and housing, issues with health, issues of discrimination or the justice system itself, inadequate social supports, and even family supports. These often contributing or part of mental health and addiction issues. And so they go to get help, and then they find that there's barriers to service access. There's mental health literacy piece, then there's this no ID, then there's transportation issues. There's even issues in navigation, trying to find the services, wait lists, bed availability, culturally sensitive services in a lot of places is lacking. So they finally do get into treatment, or maybe they're incarcerated. There's very little trauma-informed care, very little Indigenous staff elders or other persons with lived experiences. And then when it's time to leave, there's very little in the way of transition planning, very little family involvement. There's limited AMH staffing to facilitate or support that transition process. They're discharged or they're released, and then there's limited aftercare and supports. No ID, which means they have limited service access for further supports. Not much in the way of transitional housing. A lot of these people are disconnected from family, so very limited family supports. And obviously, a lot of them are contending with homelessness. And as the socioeconomic factors come back into play again, right? Housing, health, discrimination, justice. They have curfews and other kind of bail conditions. Education and employment is just not reachable at this point, right? Often leading to kind of relapse, back to issues with addiction and or mental health, depression, anxiety, almost hand in hand, quite frequently leading to criminal activity, back to incarceration, or they get to a point where they hit rock bottom a second, third time, and then they're back to barriers to service access again. The whole cycle repeats itself. So this is just kind of a summary of what we've seen in terms of those continuous cycles that these high need service users are faced with and caught in. So after analyzing 9,200 answers in over 200 interviews with Indigenous service users, we identified many themes in what service users said they need. These themes are actually unmet needs, so are unmet service needs, and what we like to call opportunities for enhancement. There's 67 of them here. Maybe a couple seconds to commit that to memory. But we're not going to be able to deliver immediate solutions to all 67 of these. But what we can do is look for initiatives that will deliver the most bang for the buck. Which brings us to the recommendations. I think what I'll do here is just read the quote on the left side and kind of walk through the recommendation itself and how that makes sense. So this is a 56-year-old female in Calgary, and she says, yes, I wasn't aware of any other services. I've been sent to so many places to get help, and then they send me somewhere else. It's so frustrating. It makes me want to explode, gets me in trouble. So I get banned from a lot of these places. So support for initiatives involving service navigation staff working out of community-based organizations, providing daily on-site support, enhanced street-level outreach, and connecting people to appropriate AHS services. So many of the pilot projects we're talking about here or have started or are happening right now. We're starting to see a lot more of these service navigation staff in hospitals throughout Alberta. Value Mental Health Action 6 strategy talked about using peer mentors to support navigators. AHS is also in the process of streamlining navigation by developing pathways between services. So we're making headway in this particular area. Remind you all that this is going back 5 years that this project was completed. So. I talked to a residential school, to a counselor once, only once. She told me it was in the past and I had to get over it and move on. It's hardly consistent with what we would call trauma-informed care. So here we're talking about implementation of trauma-informed care. And of the 200 participants that we interviewed for this project, 41% of them were residential school survivors. 75% of them had participants, 75%, excuse me, of the participants had a parent or parents who were in residential school, 75%. Legacy of residential school is alive and well, and as many of these residential school survivors had children who are now middle-aged adults coping with the effects of intergenerational trauma. Those that were beyond the reach of the residential schools fell victim to the 60s scoop, in which government scooped an estimated 20,000 Indigenous children, placing them in foster homes or even overseas adoption arrangements. This is a practice that actually began in the 50s and continued into the 80s. So at the levels of trauma Indigenous people endure, trauma-informed care needs to be the cornerstone of addiction and mental health intervention. AHS is in the process of implementing trauma-informed learning modules for AHS staff, but it shouldn't stop there. Services need to examine service delivery with the trauma-informed lens to further identify those opportunities that'll make their services more trauma-informed. Brings us to recommendation 3, the rural and remote communities. So there's a lady from High Level who's 45. She says, the waiting lists are too long. There's a 3-month waiting list. This needs to be shorter. Even the walk-in mental health. It's a good idea, but I have to see a different worker every time. I have to explain my whole story all over again. Yeah, what's that called other than re-traumatizing, right? So they need to offer support and services to these young families through things like home visits. If they don't have transportation or childcare, how are they going to access these services? These communities are remote, some of them 45 minutes away from services. So Indigenous communities are a ticking time bomb of mental health need. December 2017 to January 2018, there were 14 suicides in one Indigenous community in Alberta. It's not a matter of if we'll see another one of these, but when. Rural and remote communities are especially vulnerable. So we need to look at how we can better engage some of these communities, how we can create or facilitate easier access to addictions and mental health services. One of the recommendations we've made here is expanding telemental health into some of these kind of more rural and remote communities, and ultimately using technology. We're trying to access technology that can communicate with these rural and remote communities. Partnerships with receptive Indigenous communities or organizations, partnerships with FNIB and Health Canada and Alberta Health. Okay, this should be a joint effort across all jurisdictions, across all governments and health authorities. So with that, we'll go to recommendation 4. Recommendation 4 was the elders and cultural programming. There was a lot of times I would like to smudge after counseling session, but it wasn't allowed, said a female who's 24 in Edmonton. Some male, 33-year-old male in Fort McMurray says, no, not at the hospital, nothing. They have a church in the basement, but no gathering place for Aboriginals. So we're talking about support the opportunities to expand the use of elders to complement existing AMH staff and services, looking at opportunities to accommodate cultural traditions and belief in service, cultural traditions and beliefs in service delivery. And when we asked high-need service users in recovery, what was the factor that influenced your recovery the most? 22% said treatment centers, 22% said it was family and friends, but 35%, by far the biggest percentage, said finding their culture and spirituality was the biggest factor in sustained recovery. So it only makes sense that we start to look at opportunities to build on that strength. Cultural competency training is now mandatory for all AHS staff, 130,000 staff. But we need to go a step further. We need to look at further opportunities to incorporate elders and cultural programming in service delivery. Which brings us to recommendation 5. So here we're talking about service transition staff and aftercare. So 45-year-old female in Fort Chip who says they should have done follow-up and home visits so people don't feel so alone after they leave treatment. We give up a lot of our friends and family when we give up alcohol. And so that really just speaks volumes to the need for aftercare, for the need for aftercare supports, for those that if we're serious about trying to prevent relapse, then we need to be more proactive in areas of aftercare, service transition. So here we're talking about transition staff and treatment centers connecting service users with longer-term aftercare supports, education services, employment services, housing services. All of these should be part and parcel of a good, solid transition plan and should form part of an aftercare as well. So expanding the use of existing transition teams. We do have transition teams, but I feel that we need more of them. And certainly what we heard from these 200 people would support that. Which brings us to recommendation 6, the transition beds. A 53-year-old female in Edmonton, and she says, if there was some place to go after treatment, most people just get out and go back to the same street, start using again. There are no other options. 56-year-old female in Calgary says, I think they should help us get housing before we're just sent away. A lot of landlords see you're native and they won't even show you the apartment. So how am I ever going to get off the streets on my own? AHS continues to explore options of transition beds and step-down bed availability in many of our zones. Transition beds like E4C in Edmonton and the Fresh Start Recovery Center in Calgary have recently opened up. If we're ever going to break the treatment-discharge treatment cycle or the incarceration cycle, transition bed utilization needs to form part of the care planning process at the front end. We need to move away from using these beds in a crisis response capacity. Which brings us to recommendation 7. Excuse me. So this is a 49-year-old male in Calgary who says, when people are leaving treatment, they more or less kick you out at the end. When I left treatment here, they drove me to the bus depot and dropped me off. I left there, they kicked me out, and I had nowhere to go with my bags. I was worried and I was scared and I had no place to go. I ran into some people I knew and I didn't want to drink, but I just didn't know what else to do. 58-year-old female in Edmonton says, people who live on the streets have a hard time letting go of that lifestyle, so they get kicked out of every place because they let family and friends live with them. Here, Ambrose Place, there are rules, but they are flexible and they're safe. Harm reduction housing is an essential resource in the fight against homelessness. In some cases, it's the only way health services can consistently engage the service user and provide necessary care for people with chronic health conditions. Harm reduction beds, like those at Ambrose Place in Edmonton, they're being recognized for providing excellent care to vulnerable, hard-to-house populations, as well as overall cost savings in terms of lower emergency department admissions, shorter hospital stays or less hospital stays. Residents of Ambrose Place, for example, have been able to achieve a 31% decrease in emergency calls, an 81% decrease in days spent in hospital wards, and a 58% decrease in hospital admissions. So when you look at the cost savings ratio, these investments only make sense. Valuing Mental Health Action 13 talks about committing to incorporating harm reduction approaches to service delivery, planning and delivery for Albertans 15 years or older. So again, we are making some headway in these areas of harm reduction housing. Just not as quickly as some would hope. So what's next for IPJ1? Well, as I said, a number of the IPJ steps have been included or incorporated in a number of different strategies throughout the organization. Calgary Recovery Services Task Force actually implemented a number of the recommendations in their final report as well. Resulted in a task force that has now evolved into different working groups to progress those recommendations in Calgary. That particular project report was signed off by a number of different government officials and government representatives. This particular project too has been, I presented this to a number of different kind of strategic planning tables across AHS, across all zones. So it's something that continues. It's a work in progress. You know, we know in healthcare, change is slow, but change is happening. That will move to the IPJ2 recommendations. Try to get through these here. Interest of time. So the first narrative there, or the first quote there is, why aren't the addiction and mental health services trying to help people when they're young? Why wait until they're in the system when it's too late? And again, that really speaks to this kind of historic crisis response model that we have in addictions and mental health. Why not look at earlier intervention? If we always say prevention is the best medicine in health, why do we not use that philosophy when we look at addictions and mental health? Why do we not emphasize that philosophy, I suppose I should say? But here I'm talking about a young offender patient journey project. So there was very limited access. Obviously, the youngest person in this particular project is 18. So we really need to look at the young offender patient journey and what specific needs they have and how different they might be from the adult population. And again, looking at that trauma exposure and how that shapes service needs. So with that, we'll move to recommendation 2. So here's a 26-year-old female, Saskatchewan correctional, and she says, there could be more Aboriginal mental health workers who are culturally aware and can do outreach. Workers who understand what Aboriginal people have been through and their traumas. You know, that again speaks volumes to just how much these people are familiar with their own service needs, their own trauma exposure, and how that needs to be part and parcel of any effective treatment plan. So here we're talking about Indigenous diversion services in the communities. We need to identify communities with service demand and staffing capacity. We can support them with team training and development. And the next recommendation here, recommendation 3, kind of carries on from that, talking about Indigenous diversion staff. They can be deployed to communities who don't have the capacity for their own diversion team. Again, enhanced service engagement will mean better outcomes. Okay, so I will just, I guess I will read this one. So this is a 35-year-old male in Edmonton Remand Center. It said, in Edmonton, there are no Indigenous staff, and it makes a difference because when they're Indigenous, they bring cultural and Native spirituality and practices. In Gerard and Eagle Lodge, they were all Indigenous, and it helped. This 49-year-old female says, the program was Indigenous and supportive, but other programs do not have Indigenous staff, and they cannot really understand my lifestyle as an Indigenous person. So we can do cultural competency till we're blue in the face, and that's a really good thing. Cultural competency is extremely important. Culturally safe services are important, but there are always going to be a need for more visibly Indigenous staff in a lot of these services. And I think that's something that's a lot of people are reluctant to say, but I think it's, the service users are quite clear. This is something that they need to see in effective addictions and mental health services. Brings us to recommendation 4, and that is increased access to elders and center. So the narrative there is a 40-year-old male, like I said, addiction and mental health services. They need to have an elder on staff or a native counselor that can connect people with their culture and resources in the community so they go to sweats and round dances and ceremonies. This gentleman in Calgary, 59-year-old male, says, I think MH services need to be rooted in culture for Indigenous people. Indigenous people. Most addicts do not have family, so you need something to connect you to sobriety. And some of these points are just so poignant and so on point. You need something to connect you to sobriety. They understand that. And I think it's time we start to understand that too. So again, support for increased elders in center. When I say in center, I mean in correctional centers. Support for equitable access to spiritual guidance and support for AMH service engagement center. Brings us to recommendation 5. Narrative here saying a 28-year-old female saying, I think it's important to have counselors with life experience rather than book experience because it's harder to open up to people who don't have life experience because you're afraid of being judged. That was a real common theme, and a real, yeah, we just heard it time and time again. Afraid of being judged. Poundmakers Lodge, because it was spiritual, cultural, because they were former users and they understood trauma, needed therapy and treatment. So again, support for more persons with lived experience and employed in corrections-based addiction and mental health services. And we're ultimately aiming for a balance of clinical AMH, lived experience, and cultural inclusion. I quite often get these questions about addictions and mental health services where people will say, what are your thoughts about this one service in addiction and mental health in Calgary that only Indigenous people are allowed to go to? And I'd say that's fantastic. You know, that's a step in the right direction. And then they're like, well, doesn't that kind of de-skill our other staff in other areas if they're not having that exposure to these Indigenous clients with these unique Indigenous needs? And I don't think that there's a simple answer here. What I know to be true from listening to these 200 service users is that some of them wanted cultural services, some of them wanted spiritual services, some of them wanted to speak to elders, some of them wanted to go to services in their own community. Some of them didn't want to go to services in the community at all. Some of them didn't want to see an elder or cultural, spiritual services at all. So we need to have a diverse spectrum of services, a diverse kind of continuum of services. And I think that means having a balance of clinical AMH, lived experience, and cultural inclusion. So with that, we move to recommendation 6. Get this mouse to work. There we go. So there's a 54-year-old male in Calgary who says, no, that's a problem with addiction and mental health. They do nothing to address trauma. There needs to be a focus on this instead of just choice and consequences. This 43-year-old male in Lethbridge says, no, not at all. I seen a friend die. Nobody ever asked me about that. My wife hung herself in 2003. Nobody ever asked me about that. 35-year-old female in Saskatchewan says, the awareness in the community needs to be more about mental health. There's a lot of awareness about addiction, but there needs to be more focus on trauma and mental health in the community to get to the root problem of addictions. So again, we're back to trauma-informed training for staff in the correction centers, for not just the AMH staff there, but select correctional staff where and when possible. And you could see the possibility here in terms of diffusing situations, in terms of recognizing PTSD. There's plenty of opportunity there and plenty of possibility for really good outcomes. Which brings us to recommendation 7, which is looking at the review for AMH FTA and corrections. A 27-year-old male says they need more CTT workers and addiction counselors in center. Everyone in here has addiction problems, everyone. There should be more active screening for AMH programs in the center. Test them on the info provided to see if they're committed. It's a 35-year-old female who says, we need more mental health workers in Fort Saskatchewan rather than just one worker who comes in once a month. And even then it's hard to see her because she has to prioritize who she sees. So again, looking at a review of FTE in the corrections, addiction and mental health FTE corrections. And then recommendation 8. So this is a 26-year-old female here who's saying, help people fill out forms to get ID and status cards or apply for financial funding. That would help them, especially if they don't have a phone. If they can get that ID, help them get in the programs. This is a 25-year-old female in Fort Saskatchewan who says, I first accessed addiction and mental health services while I was in provincial jail. You can access services without a picture ID or have help getting your ID. We apply, get accepted into treatment, and then get a medical rather than needing the medical first. So many Indigenous people, men and women, leave correction centers without ID. ID is the main requirement for accessing many of the services and supports. Without service and supports, most will return to previous coping strategies, as we've seen in the cycle graphs previously. Return to those old coping strategies and behaviors, and the cycles will continue. Okay, which brings us to recommendation 9, which is, oh, I guess there isn't a recommendation 9. Okay, you guys are off the hook. So what's next for IPJ2? Well, the IPJ2 highlighted a number of different challenges faced by Indigenous service users leave custody and try to access AMH services. We're continuing to meet with leaders in addictions and mental health to look at these different opportunities that we can make some of these changes that are needed. Some of the IPJ2 recommendations were addressed in Value Mental Health Next Steps, specifically the expansion of the diversion program. So we're really hopeful about that. 1 year after the IPJ2 project, I was contacted by a lady in AHS Patient Relations Engagement and Patient Experience. So they had analyzed 601 addiction and mental health patient complaints from a FACT database. And the themes they pulled from those 601 complaints match our themes almost identically. So we felt pretty validated that we identified the gaps in AMH services delivery as the service users see them. So there was this kind of objective validation for the people in patient relations. That's about all I would say for that. I would move to next slide. What can we do? Well, there's plenty. Let me just find my notes here. Some people may look at these recommendations, I think, and say, I've been saying this for years, and I have no doubt they have. What this says to me is that when it comes to vulnerable populations, the need continues to grow in demand and complexity, and yet our services tend to evolve very little. The good news is that we're starting to move forward on a lot of these areas now. And what can we do? I think what I would say here is, I'll just give you a note. I'm sure a lot of people are curious as to what these bags are here. So these bags are property bags that your property is taken away from you when you're arrested and taken into custody, and they put your property in these bags, whether they're shoelaces or wallets, watches, jewelry, etc. Put them in these bags, and then you get them on the day of your release. They give it back to you. Well, these bags I see every morning on the train station, at the train station grounds. It really speaks to, again, that kind of transition planning. You're just dropping them off at some random train station out in the sticks. Train station that's closest to the remand center. You can see that one bag there has a card in it. You pull that card out, and it was a referral card for addictions and mental health services. So what can we do? Well, we can advocate for equity in health services delivered to Indigenous populations. We can hire Indigenous staff. We can start to look at more opportunities to include the voice of lived experience and the service and the design and development of services. Look for opportunities to implement or expand trauma-informed care. We can examine the patient journeys from front to end, identify the choke points, barriers to service access, opportunities to support the patient through the transitions for the most vulnerable. We can look for ways to be culturally inclusive, but also ways your service can reflect a genuine commitment towards Indigenous reconciliation. Listening and learning to Indigenous patients will mean the difference between equity and equality in health services. Ego say, hi. That's it. Thank you. we have time for questions?
We have time for probably a couple. We've had some good narrative happening in the chat. A couple of resources were flagged, a couple of kind of bright lights. So thank you for those that shared those. We did have one question come in from Mike, and he is asking for insights and recommendations specifically regarding aftercare. What is the best mechanism to arrange for supports to subsequently communicate with them post-discharge, or even often reminders, like many of us would receive reminders on our cell phone, but when people lack housing, a mailbox and phone, you know, what options are there, or what kind of suggestions came forward perhaps in your dialogue with folks?
I think aftercare, the cornerstone of aftercare really needs to be that kind of clinical relationship. And it's a more personal relationship, a personal connection to the person in question. And I think you know, your challenges with aftercare are always going to be huge, with particularly vulnerable populations, the indigenous populations. They don't have cell phones, or they don't have a fixed address. It really speaks to the importance of those kind of warm handoffs, or even transitions, supported transitions, where you can continually remind them, you know, where they can call when they need support. But that support needs to be accessible as well. You know, it needs to be, they need to have supports that are available when they need it. And that is not 9 to 5, Monday to Friday. So we need to start looking at creating more flexible services to accommodate things like transition and aftercare. And I think the sad reality of most addictions and mental health right now is that there's very little capacity to look at things like transition and aftercare. We are constantly working in a kind of crisis response mode. So I think we need more staff ultimately, but more capacity to address and focus on things like aftercare.
I love the approach that you've used with Alberta Health Services of the patient journey map, and we've used a very similar approach in Saskatchewan to help us understand that you know, as practitioners or providers, you know, we only see a brief moment in time in that larger journey. So I think it's just such a powerful, brilliant way of linking together all those pieces, and then bringing that lived experience voice of the gaps between those pieces, right? We don't often organize around a whole continuity of care for a patient. You know, as practitioners, we typically interface with them at one point in time, perhaps 2 points in time, but stringing it together to understand what that entire process looks like is just such a powerful, insightful tool. But I also think it gives you a great roadmap forward to identify the multitude of things that need to happen in order to support that outcome towards recovery that we want to see. So I apologize that we are at time for today. Thank you so much, Randall. The chat has been busy with lots of notes of thanks and lots of interest in reviewing your slide deck after the fact. So just as a reminder, we will post the materials from today's session to our website by the end of today. So thanks again for your time. Just to call out that Randall was actually our first person who went through this process, and we are so glad that he did to sign up to share with this learning community. So if you have some experience, a story that you would like to highlight within our QI Power Hour learning community, we invite you to become a QI Power Hour speaker. So as a small token of thanks, Randall, you will get these delightful socks that say I love QI on them, that we hope you will wear proudly in your endeavors to improve access to care within Alberta. And in the spirit of continuous improvement, as always, we welcome your feedback on today's session. So we are always looking to improve our sessions and make them as valuable as possible to our learning community. So we do invite you to provide your feedback on today's session. Just a note that you may get this prompt that comes up, just letting you know that you're being directed to an external site. But no worries, you know, you're not going to get a virus, but we do welcome your feedback for today's session. So with that, just a note that we will be breaking over the month of August, but we will look forward to seeing you all in September again with our new lineup of speakers. So have a great summer, everyone. Thanks again, Randall. Take care.
Thank you.